Let's circle back though a little bit about the ARV7 and the role of taxanes again, because we know that there has been a couple papers that suggest that if the patient expresses this splice variant, is positive for this, that the taxanes actually, we know you shouldn't give them an androgen axis modulator, but taxanes apparently do have some efficacy in these patients. Give us the mechanism behind that, or proposed mechanisms behind that.
Yeah, I think one of the challenges of the splice variant topic is what Chuck mentioned. You know, not every patient has it, number one, and number two, when you look at actually perhaps the biggest utility of a market like this, in my opinion, would be just that in a cost containment situation as the healthcare is moving into that sort of management style, right? The only thing that if you were to have a patient with a splice variant, then you know that you're gonna save that patient access to expensive therapy. But I remind you that it's only in around 25 to 30% of patients where you see that splice variant. So the question is, what happens with the other 70% of patients, right? And how those patients are actually becoming resistant to the existing agents that we have. Now, I think that the data with the splice variant and whether or not harboring that splice variant will impact your ability to actually respond to taxane, I don't think we really actually understand, really well that. Now, what is more intriguing to me is that if you look at the existing data as to what happens to a patient that undergoes primary therapy with either enzalutamide or abi, and when they become resistant to that therapy, is how do you actually manage that patient? And I think that, clearly, if you have a splice variant, I think with the limited data we have, I probably won't put that patient on an oral agent. But the question also becomes, if you actually don't have that splice variant and you get on therapy, are you developing in the future a similar ligand binding mutation that can actually lead to resistance? And that's something that we don't know. So I think for most of us at least, I don't think I will use a splice variant to actually make my choice as to who needs chemotherapy, right? I think that it remains a clinical question. I think it remains as who's in front of you in the office and what are the needs of that particular patient. But I think it's important to emphasize that, for instance, back-to-back oral therapy is just not the most intelligent strategy to undertake in the context of where we are. We know with even limited data, right, that if you start with abi and then you move the patient to enza, the likelihood of benefit, whether it's PSA measure and or progression-free survival, is pretty low. And if you start with enza and move the patient, whatever agent you start, back-to-back oral therapy is not the smartest strategy with the data that we have. So clearly, the biggest question becomes, if you have someone who actually progresses on an oral therapy, knowing that back-to-back oral therapy is not the most the best therapeutic strategy is, what did you do for that patient? I think most of us, outside of a clinical trial, will move that patient to systemic chemotherapy.
Can I make
go ahead.
I just want to make a quick point. I think that the ARV7 story, for all of its excitement, is just one piece of the molecular profiling that we're beginning to do. There was a paper in the New England Journal of Medicine this week or last week about BRCA2 mutations and the importance of that in prostate cancer. So I think moving forward, it's simply not going to be acceptable to not understand some of the molecular biology of the disease. Androgen receptor, glucocorticoid receptor, DNA repair, these are all emerging. These are all coming to prostate cancer from other cancers where it's done more routinely. And I think that in 5-10 years, if we were to repeat this conversation, we'll have a whole panel of molecular profiles we'll need to be looking at.
But isn't that the exciting thing right now with taxane therapies, that really it's independent of the androgen receptor?
Correct.
They work. So that's the good news. If you look at the data, we're even looking now at being able to identify molecularly which taxane may be better, depending on, such as the retinoblastoma, loss of the retinoblastoma gene, which was developed at Thomas Jefferson, Joel and I's alma mater, that study showing that cabazitaxel may be a better drug in that setting. So I think we're really getting down to some benefits of even the taxane therapies here.
Judd, do you think we need to be more aggressive, understanding that these are mutations and that prostate cancer, especially in the CRPC, is a polyclonal disease? I personally don't think, and I'd be curious to see what you guys are doing at Duke. Are you being more aggressive in terms of doing biopsies of the met, especially bone?
Great question. So we have a protocol, and they're selectively doing that, but it's for research purposes. And Whether that will play out in the trenches with routine clinical care, I don't know at this point. My suspicion is it will, because we're just starting to scratch the surface and as the technology has improved. But as a urologist, one of the practical questions, let's say a urologist tuning into this program, has a patient with newly diagnosed early M1 CRPC, and he or she is trying to decide, on an oral agent. Is there a phenotype of a patient who should go directly to chemotherapy? I think is there, aside from the molecular standpoint, from a practical standpoint, when should the urologist not do an oral agent and say, look, I need to get this guy to a medical oncologist, he needs chemotherapy immediately?
I think if the data with the splice variants gets really validated, right, and is indeed the reason why someone should not move forward to an oral therapy, it doesn't really mean that that patient should go straight forward to chemotherapy either, right? Because if you have someone who has no symptoms, who feels great, who's interested in quality of life, but who harbors that splice variant, it doesn't really tell me, I don't think like that way, that patient needs chemopherapy immediately, because timing in that context also hasn't been tested, right? We don't know if starting someone on chemotherapy, when you have one bone lesion is better than when you have two bone lesions. Granted that we now understand that maybe earlier for selected patients is better. But I think the biggest question when I think of this type of testing is, I think that if I were to harbor, if I have prostate cancer and I have to harbor that mutation, then I certainly don't want to be on that oral therapy, right? But it doesn't tell me what is the next best treatment for that particular patient, and that's the biggest question. So I think most of us, at least in the GU medical oncology space, continue to utilize clinical features, prognostic factors that have been tested over time to define who's the right candidate for chemotherapy. And I don't think a molecular test at this point is prime time for us. In fact, if you look at the data from the Bono that was just published, as Chuck just mentioned a couple days ago in the New England Journal of Medicine, again, looking at DNA methylation changes, and whether or not PARP inhibitors are really the best therapies for patients who over time, they may develop epigenetic changes in their tumor, right? But if you look at their data, only 30% of patients have those epigenetic changes, right? And if you have a patient, for instance, that have a BRCA2 deletion specifically, right, who becomes castration resistant, would that be enough for you genomically to say, oh, I'm gonna put you on an agent that actually targets that? I don't think we're there yet. And one of the challenges, for instance, with genomics is that precisely, that we continue utilizing archive material to define what happens in the metastatic deposit. And the challenge also comes that biopsying prostate cancer patients in the CRPC setting is very challenging because most of them will have only bone disease. Not a lot of patients have soft tissue disease. And whether or not you have 3 different genomic aberrations, which one would be the one that you want to target therapeutically?
We're doing it on a large scale, as you all know, with part of our Stand Up to Cancer Dream Team program, done about 200 of these biopsies now. And it's possible, it's doable, and I think that they're going to be meaningful, but the pathologists need to be ready for this, the interventional radiologists need to be ready for this. I would also point out that there's the genomics, which is obviously very important. There's the somatic mutation issue versus germline mutation issue, which is going to need to be sorted out. And then actually histology of these metastatic tumors can tell a lot. You can't go to a prostate cancer meeting now where there's not a number of presentations on neuroendocrine and small cell phenotypes, and everybody's got or many people have their own definition and outcome analysis of individuals with small cell or neuroendocrine prostate cancer, and that's something where we need to get uniform language and uniform outcome analysis on. And that's happening. I mean, the conversations are happening. It's just that we don't have the answers yet.
Correct.
I mean, I think it's fair to say, I think like you had alluded to earlier, is that where we are in prostate in terms of molecular testing, we are 10, 15 years behind what everybody else has been doing in breast, colon, and lung.
Hopefully not 10, 15 anymore, but it's still behind. Yeah.
Okay, so let's, great discussion and lots of great points. And again, I think this is something that I believe that all the urologists need to have some basic understanding that we have these mutations, we have these variations. Putting people on these drugs, whether it be LHRH therapy, androgen axis modulators, chemotherapy, we change the tumor environment, we induce these mutations, and so this begs the question later on, which we'll have a little bit of a discussion, is about sequencing, combinatorial, layering of therapy, whatever verbiage you want to put on there. So, okay, so.